I'll try to skip through the basics that you're supposed to learn from the books, but for the exam, an idea about anatomy and embryology, you're not expected to do a lot about, about other conditions, but in the diaphragm, because most of the congenital hernias will present later in life. It'd be good to understand the embryology behind it. And then obviously the rest I'll leave up to you and up to your scientific curiosity about physiology and the rest of that. Surface landmark is important not just for diaphragm conditions when you're going to put your forks. You don't want to end up being in the abdomen, particularly when you start doing robotic surgery, you need to go low. So it's helpful to understand the surface the surface marking of the diaphragm. Also, that's a popular quiz. Sort of when you got medical students attending your theatre and you ask them about your the foramen of the diaphragm. Juliet smiled because this is, I think, from a book you have written or a chapter about. Yeah, that chapter. I will feature again. Disclosure. Now, something that's applicable to surgery in terms of the anatomy is how the diaphragm is supplied, both from arterially, venously, and innervation. This is an abdominal view, and you can see the supply of the diaphragm kind of favors if you are in the abdomen attending to a trauma and someone said, yeah, something in the chest, you're going to cut the diaphragm to enter the chest or the abdomen. You had the option. These are ideally on the right hand side, go more peripheral, more anterior, on the left hand side, most posterior. And always allow a couple of inches so you can repair the diaphragm when you can. Other than that, I think just sensible, muscles don't hold sutures very well, as much as membranous part. I think you need to be very familiar with your phrenic nerve course for your thymus. It'd be useful to relate to how the left phrenic here is entering the diaphragm, and the nerve supply comes from below. So it perforates the diaphragm and is supplied from below above. But if you notice here, the left phrenic tend to have a more anterior course towards the latter part. So when you're doing your thymus, and you're kind of not sure where the heart is doing, always be mindful that the phrenic will attack you on the left more. You'll be much closer to it on the left than you do on the right, and you're unlikely to injure it when you're doing your thymus. So, or anything around that area. I think that's all you guys need to just be familiar with. The congenital defects, there's a few of them. Again, Juliet's chapter, when I think we were training that time, yeah. So just to summarize, I think the ones you need to be familiar with is the eventration, particularly the ones you need to be familiar with is the eventration, because it presents like a phrenic nerve palsy often. So you go and try to do application, but you find your quality of your diaphragm is not great. So eventration is loss of muscularization of the diaphragm, and a good radiologist should be able to tell you the difference between them. And then you've got the Bogdanics and the Morgagnis, and I'll talk about those more in detail. But obviously you've got the more extreme diaphragmatic congenital hernias that are part of another more complex, often, syndrome. And they do come with their own challenges, whether you need to support the babies as they present early in life, and whether it's hemodynamically or respiratory through ECMO and others. And usually the babies do this will be part of many things you have to consider when you're correcting these defects, is how you correct the diaphragm. But we skip through that and just get it more into the mainstream thoracic surgery. And so the congenital hernias, more often when I see, are the late presentation, so they've been there for life, and they get worse as they get as the patient gets older. And so the Bogdanic is by far the most common one, and it's 80% tend to be equal in gender presentation, and it's more often on the right, and it's the posterior one. And I have skipped through the embryology because there's a lot more things to show. So one of the most challenging aspects of repairing these diaphragms is how do you fix it when you don't have a diaphragm to repair. So if you look at the Morgagnis, they tend to be more posterior, so that there isn't much at the back if you're going to put a mesh, so you're going to go pericostally. While at the for the Bogdanic, for the Morgagnis at the front. So usually this is where the tricky part when you try to repair put a mesh at the front. The intercostal, the bone, the ribs are wider, the intercostal spaces are narrower, trying to pass a suture. So they're harder to repair, and they are the one to take seriously. If you see a Morgagni, it's normally small, trivial, patient might not have any symptoms. These are the ones that's going to come a few months later with a letter from you saying, treated conservative management and came in with bowel obstruction. So Morgagni, the smaller the defect, the more dangerous the hernia is. So the ones that tend to make us, get us excited are the big ones, but the small ones are the ones who tend to bite. So be mindful of that, and the sort of workup you need to do for repairing these diaphragms. So as I said, the main problem is either a volume issue, that you've got a chest full of abdominal contents, so the patient will come to you with breathlessness and all the symptoms related to decreased respiratory function, or you're going to need to offer them an operation prophylactically to prevent incarceration. And clearly, if they already come incarcerated or with bowel obstruction, this is a general surgical problem, so they are dealt with laparotomy. In general principle, your best way to repair a hernia is from the abdomen. It's one of those things, it's at the fence, it's slightly difficult to establish which way to address the diaphragm. We've got two major conditions. Plications for palsy, and hernia is the other condition. So the hernia, try to address it from the abdomen more often than the chest, because it's a bowel issues you have to deal with. And the general surgical approach to that is something that all hernia surgeon uses, something called the double crown technique. And the idea is you would put a tension-free mesh, and you would want to have an area of contact between the mesh and the tissue to prevent recurrence. The third, not too very dissimilar from in presentation, is your traumatic delayed presentation, or in fact they could present immediately in the context of trauma, and you have to deal with them if you're doing a laparotomy. And the percentages are there. These slides are already in your USB stick, so you should be able to get access to them. The main issue is the ones that come to you late presentation, and you have to deal with them the same way you deal with the congenital ones. These ones you would know that they've already been either beaten up before or got some sort of a road traffic accident, and you'll be more suspicious about that. So, so as I said, the general principles, you want to approach these diaphragms from the abdomen, and there is a continuous effort to do it minimally invasive. And usually when you've got a very large hernia, it's difficult to just settle the diaphragm. So historically we've been doing thoraco-abdominal. There's a series of presentations about people attempting laparoscopy, VATS, one or the other, or trying both. So there haven't been very many successful attempts, or at least published reports. I think people who are doing it tend not to publish. I think there's a group in Dublin have presented this series. And we have, sorry, I've gone the wrong way. I'm going, wait, that's why. Okay, so and when I started here, there was well, we were doing a couple of those, and they used to stay long, and we thought, well, how we could address this. So I sat with the upper GI surgeon and said, okay, what would stop you from doing it from the abdomen laparoscopically? And having a discussion with them, they're quite happy putting all the bowels down. They're quite happy putting mesh, do laparoscopic suturing, but there are two areas that they always find difficult, and in fact, we got called once when they tried to put their mesh near the heart, and not stapling into the heart, patient tamponaded. So we worked out that it'll be a collaborative effort, so we don't get called when the situation is really bad. So we found a way to let them do the bit that they do the best, which is suturing the defect all around here. And the two areas that they struggle with is when they have to get around the back or around the front, when the ribs are, they can't get around it laparoscopically. And near the heart, you don't want them to get anywhere near it. So with that in mind, we devised a procedure with a very good colleague of mine in Heartlands. And he'd start through laparoscopy. Rena's area presented those cases when you worked with me. So he start laparoscopically, and they put 5 ports. They're all very well described in your booklet, in your USB stick. And then they will pull the bowels. They put the mesh in the abdomen, and they will fix it loosely in the area that they're most comfortable with. They leave it away from the rib, and they leave the edges thrown inside the chest for me to go into a second layer from inside, get as close to the heart as I could there, and go around the ribs. And that's the general principle. And then I'll turn them, and I had started doing VATS. Again, I got proctored by Joel to do my VATS application when I first started in 2017, and we took the same approach and started suturing those. I'll just show you quickly. This is a very sped up operation to achieve this kind of repair. So first of all, you can see this is laparoscopically pulled all the bowels, and then they've got, in congenital conditions, occasionally you find that the bowels are extrapleural, so you have to dissect them, bring them down. But again, if you've got a very good colleague, here you can see the spleen is kind of in the chest. You're trying to flip it into the abdomen without maneuvering it. So 5 minutes, I'm going to be quick. And then we just put the mesh. They loosely fix it, and then I'll go inside. Anyway, I'll go inside here, I think, and I'll do the second layer through the abdomen. Here's going down through the chest, going down the ribs, and I thought I'll put the slide because what Joe was saying about a cardiac arrest from the heart being pushed. This is the latest one we did. We did a series of 6, and they all did well. The latest one, you can see how severe it is, and we've done the abdominal phase, just a learning point. And when we turned her on her side to do the chest, she's arrested, and she would not come out. And we did not do the second phase, but she survived it. She's fine. She's still done in one phase, but you can see how severely this can be with the heart being shifted or to the other side. Anyway, so this is the group patient demographics. Since then we did the extra 2 of them, and these are the causes of Yeah, and the next main one is the paralysis of the diaphragm. Again, these are the causes. You need to be familiar with them. The one thing in mind that you should keep in mind is your dysfunction of the diaphragm is not just the paralyzed diaphragm. Is the contralateral diaphragm is also dysfunctional because it needs it's pulling against a loose anchor, which is the other side. And we've demonstrated that. Professor Naidu from the unit has done an elegant work imaging the functioning hemidiaphragm, and it showed how different it is. And it's generally, it started as thoracotomy and now become very popular VATS operation. What's the advantage about VATS operation is you get to compress the chest with CO2 and you get to work with a very flex diaphragm, so you don't have to fight with the abdomen all the time. And I have this theory that actually you could do a better plication with VATS than you would with thoracotomy. Might be shocked for that. And but in the end, you are doing a symptomatic operation, similar to LVRS, and you want to make sure that the patient gets the most benefit. So, from your point of view, you want to make sure the patient is really symptomatic. You're not just treating a raised diaphragm. They do have a diaphragmatic dysfunction, and if you've got paradoxical movement, you go more empowered that you can make things better, which means you're even going to improve their contralateral side. And finally, you want to show that the lung function gets affected one way or the other, and what's better than a supine and an erect lung FEV and FEV1 and FVC. And we looked at the data when we adopted this method, along with having objective assessment of their function of their breathlessness. And we found that MRC has improved significantly in this group of patients of the series that we've done through VATS only, and since then we moved away from VATS to RATS. And then again, in terms of the lung function improvement, there was a tendency in the small group of patients that we had since I've got proctored by Joel. But the most interesting finding for me is why FEV1 is improving. FVC, we understand FVC would improve if you titrate the diaphragm, but why FEV1 improves better? The diaphragm is still not moving, and this is just to confirm that your functioning hemidiaphragm works better in a plicated diaphragm, and you can see that the improvement in FEV1 is often better than FVC, although we tend to look at FVC. So I think plication is a good operation. I would strongly recommend VATS as a procedure because, as I said, you get to compress the chest and you do a good plication and under tension free, and you tend to be able to tighten the diaphragm down. Some people will tell you, well, you are suturing through the diaphragm, and how do you know you're not injuring the bowels underneath? And that was the advocates of doing thoracotomy, open the diaphragm, do a double-breasted repair. But Joel's published 50 of his cases. I don't think you've reported any injury to the bowels in them. I've read it.
Definitely not reported it.
Never reported it, and I trust you. And I haven't had any of those either. In fact, I was so paranoid about it. I once done one really, really bad. So I've had it since he was 7. He was 77 when I plicated him. And I just got so paranoid that I told the jaw surgeon to put a camera in the belly and show me what happens. So they did that, and all you see is another second stomach, which is the plicated diaphragm. You know what is that? Is that pouch? And but nothing. The bowels are always very difficult to catch because the diaphragm tends to be very thick. And if you're sensible in your bites, you'll be fine. So these are the two different techniques in VATS or the double-breasted. Again, they are in your slides, just in your USB. And these are some pictures from John's, I think, article, and this is the, I think this is the biggest series on VATS that there is out there, VATS plication. And again, it showed what we have shown, improvement in MRC. A little novelty, some of you who did this course probably would know about it. What is the relevance of a horse and Superman? How is that relevant to this talk? No takers?
You fell off the horse, broke his C-spine.
Correct. That's right, and that's him. Is it Reed? Christopher Reed, that's right. So yes, he was the first one who, or one of the early patients who got an FDA approval for diaphragm pacing. So I thought I'll give you just general principle about diaphragm pacing. You will get a letter from the respiratory physician for a phrenic nerve palsy. Could you consider this patient for pacing or plication, or sometimes they send you for pacing. Now, the only indication for pacing is something called upper motor neuron defect. The diaphragm, the phrenic nerve, if it's cut between its the neuron in the neck, anywhere between there and your diaphragm, you cannot pace it, it's gone. So you get fibrose. So the only indication is obviously from the from either central or like ALS or central nervous system defect, or spinal injury above the nuclei of the phrenic. It took a bit of a bad publicity because of the DIPAL randomized control trial, which was published, had to stop early because there was a lot more complication in the surgical arm. There are some major flaws in this trial. They used abdominal approach, understand that. They tried to pace the diaphragm directly with wires, and rather than trying to pace the phrenic in an intact phrenic, so they bypassed the phrenic altogether, thinking they could overcome a dysfunctioning nerve, but technically speaking, the innervation will not be the same without the diaphragm. And I think that's, just be aware of all the other condition, which is the hiatal hernias, which is an upper GI issues, and the rare tumors. Thank you.